dear fellows, friends, students and colleagues. Actually, I was taking some of the lectures, tutorials on hematology as internist, how I look hematology. Now this is I'm Professor Syed Ali Haider, and representing as a visiting professor of medicine, Jinnah Medical University. Previously, I have done sessions on CBC interpretation. Those people who have not seen those videos should see these videos, because they are very important parameters which were discussed previously. Very important parameter. So the approach to the patient with anemia. Let's see the RBC, the important players. RBC, the hemoglobin. It is reversibly bind and transport oxygen from the lungs to the tissue. This is the prime function. Hemoglobin, 4 globin chains, and iron and other accessory functions are there. So it is most powerful. It is buffer of the body. Then, relating with this RBC, the iron play a key element in the production and hemoglobin absorption is poor. It will lead to the problem. How the concept is coming. Iron needs the transformation from the ferric to the ferrous in the presence of acidic environment or in the presence of a small amount of the ascorbic acid. Transferrin, now it is absorbed. It is iron transporter protein. It binds the iron and carries to the liver, where iron is required. Where it is required, it will be transported to the hematopoietic tissues. Ferritin is the iron binder, and it is the major of the iron stores. Actually, it's stored as ferritin. And there is again another protein which is called apoferritin. It is also acute phase reactant, means that it will be increased in inflammatory conditions, in a nephropathic condition, in the stress conditions. Ferritins. For example, if the hemoglobin is low, the ferritin is high, then what will do? No, this represents the acute phase reactant, just like glucocytosis, thermocytosis, ESR, CRP, ceruloplasmin, ADH, and thyroxines, etc. These are the acute phase reactant. Definition of the hemoglobin is that I have already said that it is the reduction of the hemoglobin in the normal blood volume or in the high blood volume, but not in the low blood volume. There are 3 parameters: hemoglobin and RBC count, and hemoglobin, that is HCT, hematocrit or PEC cell volume. If 2 parameters are significantly decreased, there is no doubt about it. The person is anemic. No doubt about it. Okay. Now, interpret this report. The patient had come to you, or somebody has sent you. The first parameter here, it is written, is the red blood cell. It is in count, is 1.8, while normal was 4.7. Markedly reduced. The hemoglobin percent is 6.5. Here it is 14 for that lab. Hematocrit is 19.5. Normal for that lab is 14.42. Now this decides that the patient is anemic. All three parameters are decreased significantly. It is 100% sure about it. At least 2 parameters, RBC indexes, should be decreased. If it is decided, then it means the patient is anemic. Now step 2, that see the mean corpuscular volume. Follow this thing, that is important. Normally it is 80 to 100. If it is less than 80, it is microcytic type of a anemia. If it is macrocytic anemia, more chances is that it is iron deficiency anemia, more chances. Or you can go for the other anemias, like for example anemia of the chronic origin and some of the hemolytic anemias. And in case of the thalassemia minor, it is possibility of this. And if it is this, then it can be measured by the iron studies which I have given previously, or if it is you can go for the other causes as well, serum lead levels, for example hemoglobin electrophoresis. To describe this is microcytic anemia. If the iron studies are abnormal, it means there is no doubt about that it is iron deficiency anemia. No doubt about it. If it is not like this, not markedly reduced, I will say. For example, the mean cell hemoglobin is 36.5. In normal was 27. It is higher rather than low. It should be low in iron deficient anemia. Or MCSC should also be lower down. This will be lower, or these three will become lower in iron deficient anemia. But in cases of the thalassemia minor, all the patient is anemic and microcytic, the parameters MCHC or MCH, they will not be significantly decreased. Although there is decrement is there, but not significant. So it means that it is a microcytic hypochromic type of anemia. If it is not, then you go for the hemoglobin electrophoresis and see whether the patient has been suffering from thalassemic type of syndrome or not. And that is very important. And now, here in this case, if the MCV is normal and the patient is anemic, and MCHC and MCH is not significantly decreased, it is called normocytic normochromic anemia, which is seen in cases of the chronic diseases originating from the chronic illnesses. There are a lot of diseases starting from anything, like tuberculosis, like chronic kidney diseases, like for example, you can go for leprosy and the other conditions which are very chronic in nature, amyloidosis, for example. So it is the normocytic and normochromic, because MCHC and MCH is not significantly decreased or increased. Another condition in which the patient is anemic, like in this case the MCV lab shows maximum was 100, although in Pakistan it is 95. It is 110. The cell size is larger. Then it is called as MICROCYTIC anemia. Anemia is there, but it is macrocytic, either due to the vitamin B12 deficiency or folic acid deficiency or other hemopoietic factor deficiencies, or it may be a possibility of hypothyroidism, it may be a possibility of reticulocytosis, and reticulocytes are a big, in cases of the severe hemolysis, the reticulocyte will be increased. So it is the study should be done. If it is increased, then serum B12, serum folic acid level should be measured, and serum TSH at least should be measured. And then you see here another one, the WBC normal, index is normal, platelet count is 180, although it should respond as acute phase reaction here because the hemoglobin is reducing. And remember, the ESR will be increased. It is 1 gram reduction of hemoglobin will increase 10 millimeter of ESR. And then you have to see the peripheral blood film. We say that a microcytic or macrocytic, hypochromia or hyperchromia, target cells, the other abnormal cells, elliptic cells, ellipsoid cells, pencil cells, etc., etc. Anisocytosis means that the sizes are different. Poikilocytosis means that the shapes are different. And that is called the bone marrow hurry, means that patient is anemic and bone marrow is trying to compensate it in hurried fashion. So immature cells will appear in the peripheral blood cell, not the blast cells. Blast cells are seen usually less than 10% in this condition. In cases of severe anemia, you can see the blast cells also. Erythroblasts, for example. The peripheral blood film should be done, definitely. So 3 basic measures, therefore, will be RBC count, hemoglobin, hematocrit. So it is the rule of thumb that is 3B multiplied by 3 is equal to C. If you want to calculate it in this formula, then the rule of 3 should be used. A is the RBC count multiplied by 3. Then B should be 15, it is 15. Or it multiplied by 3, 15 3 is 45. 5 3 is 15, 15 3 is 45. Check whether this holds a good in given results. If not, indicates the micro or the macrocytosis or hypochromia. That is, you will see the peripheral blood film. There are 3 basic measures. There is a very good rule of thumb. Hematocrit means that packed cell volume. What is this? Is the erythrocytes, and the layer will come after 1 hour of incubation. Incubator is used. One layer is leukocytes and thrombocytes, another layer down is the erythrocyte, and this part is you will measure in percentage. The hematocrit is usually in our country, it is about 40 to 45% around, and this part is showing the plasma. So this is centrifugation which is given here, and it can be calculated by nowadays the computer will tell you how much hematocrit is there. Anything can be calculated by the machines we use. So these are the things. Now you can see that you can calculate the mean corpus per volume if you will divide the RBC count, the mean corpus per volume can be obtained by hematocrit divided by the RBC count. More is the RBC count, less will be the MCV, more is the, you can see the hematocrit, more is the hematocrit, more chances of MCV. MCHC can be calculated, you can calculate by hemoglobin divided by RBC count, and it should be multiplied by 10 because for the ventilator, or by the picogram. It can be obtained like this formula. So it is directly proportional to the hemoglobin in millimeter and inversely proportional to RBC count. The mean corpuscular hemoglobin concentration, MCHC. Here you can calculate that the hemoglobin should be divided by hematocrit, and it should be multiplied by 100 because you have to obtain in percentage. The first is the rule of thumb, 5 into 3, 15, 15 into 3, 45. Second, then see the MCV. I have previously told whether it is the microcytic or it is macrocytic or it is normocytic. It can be calculated by hematocrit divided by RBC count and then multiply by 10. Centiliter. It will come in the centiliter. Then the mean corpuscular hemoglobin concentration can be obtained by hemoglobin divided by hematocrit multiplied by 10. It will come in picogram, and mean corpuscular hemoglobin concentration, you will divide the hemoglobin by hematocrit and multiply by 100 because it will be described and denoted as in percentage. It will come in percentage. In our country, I said that it is 40 to 45%. Normally, MCV in our country is 72 to 95. MCH usually in our country, it is 29 to 31. MCHC in our country, it is about 32.5 or 33, you can say to 35. It will be seen in the brackets, no problem. If you can understand that how it is increasing and how it is decreasing, and that is why I have said that the two parameters should be significantly reduced to label the person as anemic. So if it is MCHC and MCH will be decreased, it is called hypochromia. So microcytic hypochromic, macrocytic normochromic, it may be normocytic normochromic anemia. Now like this you can describe. And the different diagnosis will come, the first part, the second one, and the third one. I have told you just now. How will you do this? Actually, a scenario is described here, just for a few minutes more, that Mr. A.G. is a 64-year-old male belonging to United Kingdom who has not had any primary care for several years. When he tried to give blood last week, he was told that he was anemic because clinically the patient was neglecting his symptomatology, any symptomatology. He presented to your clinic for evaluation. Why is he going anemic? For example, 14 grams is the normal one. He has the picture of like 9 or 10 grams. It means that you have to do the CBC. Take the history of this patient, go for the physical examination in detail, and after doing it, if you find something, then the provisional diagnosis can be made, and then go for the investigations, blood CBC, justifiable investigation should be done. ऐसे नहीं है कि जो है ना तुक्का मारा और शुरू हो गए, सारे पैरामीटर करा दिए उठा के, ऐसे नहीं होता है. जो FCPS लोग एग्जामिनेशन दे रहे हैं अगर फ़र्ज़ करिए कि MCV किसी का ज़्यादा आ गया है, वाज़ेह तौर पे ज़्यादा है, ही इज़ एनेमिक, और आपने उसे ये कहा कि मैं आयरन स्टडीज़ कराऊंगा, तो ये बात जो है ना वो एग्जामिनर नहीं मानेगा आपकी किसी सूरत में, जबकि वो लैब रिपोर्ट में किया गया है, वो तो पार्ट है, वो तो होगा। अब ये जो है ना, अगर पेशेंट जो है, इस पेशेंट को जो किया गया तो इसको जो है वो माइक्रोसिटिक हाइपोक्रोमिया आ गया फॉर एग्जांपल, तो फिर वो आपसे हिस्ट्री जो है कि वो इस तरह से होगी कि वो कहीं से लॉस कर रहा है ब्लड, कहीं से लॉस कर रहा है। बस सीधी सीधी बात है कि ये हिस्ट्री टेकिंग हैज़ बीन डेफिनेटली इज इम्पॉर्टेंट। सिम्टम्स को रिव्यू करें जो कि एनेमिक पेशेंट्स के होते हैं, किसी भी एनीमिया में होते हैं, एक्साइटल डिस्निया, डिस्निया स्ट्रेस, फटीग, बाउंडिंग पल्सेस, पैल्पिटेशंस, फटीगिबिलिटी, पोस्टल डिजीनेस, लेथार्जी, हाइपरटेंशन, इवन वेरी सीवियर एनीमिया कैन गो फॉर द शॉक एंड डेथ, इस किस्म की चीज़। फिजिकल एग्जामिनेशन आई से देखें कि अगर ये पिंक से जो है वो पेल हो गई है, चेहरे को देखें, ABC चेक करें, जॉन्डिस चेक करें, आई की एग्जामिनेशन की बात हो रही है। और उसके बाद जो है वो नेल्स देखें, पैलेट देखें, टंग देखें, ब्लिम्बोलोपैथी देखें, पेरिस्प्लेनिमेगाली देखें, बोन टेंडरनेस देखें, पिटिची देखें, और रेक्टल एग्जामिनेशन देखें, उसमें तो कहीं कोई ब्लड नहीं आ रहा। हेमराइड्स आर द कॉमन प्रॉब्लम इन द मेल स्पेसिफिकली। ऑकल ब्लड स्टूल में किया जाएगा, उससे पता चल जाएगा कि ये क्रॉनिक लॉस कर रहा है ब्लड का। इस तरह से एवेल्यूएट करते हैं पेशेंट। और ये सब कुछ भी फेल हो गया, आपको मालूम है कि माइक्रोसिटिक हाइपोक्रोमिया में तो कहीं और यूरिन में तो नहीं आ रहा, यूरिन को एनालाइज करें ना, तो वहाँ से भी फेल हो जाते हैं आप, तो फिर आपको फिर दोबारा जो है ना आपको पूरा एवेल्यूएशन चाहिए। इवन आपको CT थोरैक्स भी चाहिए, CT एब्डोमेन भी चाहिए, अल्ट्रासोनोग्राफी भी चाहिए, वहाँ से भी कोई क्लू नहीं मिलता, तो अपर GI एंडोस्कोपी करेंगे और लोअर GI एंडोस्कोपी करेंगे, और वहाँ से देखेंगे कहीं ये ब्लीड तो नहीं कर रहा। तो वाज़ेह तौर पे ये पेशेंट जो है माइक्रोसिटिक हाइपोक्रोमिया है, और इसका जो है आयरन स्टडीज भी एबनॉर्मल है। ये उसके बारे में बात हो रही है। एक केस को मैंने डिस्कस कर दिया है, लॉट ऑफ केसेस आर देयर। I hope because the discussion of anemia, how to go for the anemia, and specifically I have spoken about the iron deficiency anemia. If you found the cause, then treat the cause, primary cause. If it is mild anemia, iron deficient, for example, the hemoglobin is 10 gram, mild, it means mild. 5 to 10 gram moderate, less than 5 gram it is severe, less than 2 gram very severe. If it is mild anemia, then the oral iron replacement therapy is needed, ferrous sulfate, ferrous gluconate, or ferrous fumarate, etc. If it is moderate anemia, then you give this person the intravenous iron, Venofor for example, iron dextran complex or iron sorbitol complex. If it is less than 5, you give the PEG cell volume. If it is less than 2, then you have to give repeated PEG cell volumes along with the furosemide so that the heart load is decreased. And this is the summary which I have given, how you manage it. Because if I will speak and speak, and it will take hours for me to complete it. I have actually discussed for you, for all people, about the microcytic hypochromic anemia is seen and how to evaluate it. I hope that you have enjoyed, probably understood what I have said, and you should remember also, because nowadays the problem is this, the people have done the MBBS, they go for the house jobs. The house jobs, they have not been told or not been trained like a house jobbers. They came out afterwards as a junior medical officer or a medical officer, then they become RMO, which is circle is started here. तो नॉलेज में पकड़ी हुई है आपकी, गलत राहों पे जा रहे थे, किसी ने दुरुस्ती नहीं किया। ऐदन सिरातुल मुस्तकीम वाली जो लाइन थी वो हमारा काम था। भाई आपके कहेंगे ये गलती किसकी है? भाई मेरी गलती है। मैं टीचर था, मैं क्लिनिकल टीचर था ना, मुझे बताना चाहिए था स्टूडेंट को, तो मैं उसमें कामयाब नहीं हो सका। मैं अपने स्टूडेंट पे बोल क्यों कहूँ कि भाई वो डफर है या उनको नहीं आता? गलत बात है। ये मेरा काम था उनको कन्विंस करता किस तरह से एवेल्यूएट करते हैं। आई होप कि जो है कि आयरन डेफिशिएंसी एनीमिया या माइक्रोसिटिक हाइपोक्रोमिक एनीमिया की एवल्यूशन आपकी समझ में आ गई होगी। वमा अलैना इल्लल बलाग।